esophageal cancers.
Should I give it a couple minutes for people to come in, or? I guess we're not going to have a lot of time, so I'll go ahead and get started. Hi, I'm Misagh Karimi, a medical oncologist in Southern California with the City of Hope. I do majority GI cancers. And I wanted to say thank you to the organizers. Total Health has done a great job. This is a good hybrid program. I understand we have a number of people online who are also listening. So we'll go ahead and get started. I'm going to cover gastroesophageal updates from the recent meeting. That's my disclosures. You see the agenda here. So we have a number of, I think you don't have my updated slides on there.
Bear with us 1 second, and we'll run and get the computer.
I had a slide on the wild turkey hunt convention that's going on here for people who are not on site. When I got here Friday night, it was quite a scene. And then later I found out that this is actually a pretty big deal. It's a very large convention. I guess they're hunting turkey and we're hunting cancer. So. No, not yet.
Okay, try advancing for us and see if it works. Okay.
Okay, it's stuck. Ah, okay.
Sorry about that.
That's all right. Thank you. All right. So I thought we could start with early stage. There are some updates that we'll go over, and then after that we'll look at the later stage of disease, some updates from this last ASCO GI update and also from the previous ones. So this is a honorable mention. I think this is the trial that looks at early stage esophageal gastric cancer in patients with MSI high disease. Small trial. So Infinity is a very small trial, under 20 patients that are looked at treatment with double IO. And this actually shows significant promise, as we also saw previously with the rectal cancer patients. And so stay tuned for this. I think this is going to be something that's upcoming. Small number of patients, of course, but these are patients who were basically selected for the study. And this is the cohort 1 that received the dual for 3 cycles. And they also looked at the pathologic CR and also negative circulating tumor DNA. 15 evaluable patients, 1 with progressive disease, 14 underwent resection. And again, small numbers, but a good number of pathologic CR. So stay tuned. I think, again, there's going to be a lot more that's going to be coming out. One thing that's interesting here is T4 disease didn't do that well. Again, small numbers. So that may be something that may not be on the future trials, but earlier primary site seems to benefit more from this approach. Not so much the nodal status or the PD-L1 status. The next one, Dr. Sanford went over this yesterday. So this is the trial that NeoAegis that looks at comparison of, I mean, this is a question that we've been asking for a couple of decades. It used to be more relevant, I think, probably about 10 years ago, but it's still ongoing. So which is the way to go in patients who have early stage GE junction cancer? Do we go with neoadjuvant chemoradiation followed by surgery, or do we go with perioperative chemotherapy? Now, this study, this is here that you see the number of patients that are noted. This is T2 and T3 disease clinical, and they were randomized. Again, arm A, patients received perioperative chemo. Most of these patients did not get FLOT. Again, this was brought up. And about 40% of patients did not really receive the adjuvant chemotherapy part, which is going to affect the outcome. The other patients received neoadjuvant chemoradiation on the cross arm, and then followed with surgery. Primary endpoint, overall survival. Secondary endpoint, you see all of those. That also includes the tumor regression in these patients, and also postoperative complications. Now, again, these are all adenocarcinomas. This is the staging that we talked about that used EUS and PET-CT scan. And again, the quality assurance, which is important in radiation. This is the, so if you look at the demographics and the surgical patients, you see here, again, it's pretty well balanced. Now, this is what I was talking about, the MAGIC versus FLOT arm that you see. Most of the patients receive the older regimen that most of us don't use routinely in practice. And you look at toxicity again, across the board. Again, it's pretty well balanced. You probably see a little bit more perioperative issues with the cross-arm regimen. You see more diarrhea on the chemotherapy arm. And here's the outcome. So if you look at this, so this is the chemoradiation arm. You see the YPN0. So this is the results that you saw more patients who benefited as far as the response goes at the time of treatment up here for lymph nodes. PCR down here, you see that 17% versus 5%. So significantly more at the time of surgery when you had the chemoradiation. And here's the major pathologic response, 12 versus 42 for these patients. So at the time of surgery, again, you saw obviously better responses with the chemoradiation arm. Operative complications, again, pretty well balanced, maybe a little bit higher up and down across the board, but nothing that significant. And here's the overall survival. So you really don't see a lot of difference between the two arms. And so the question is, I think the question is still there. Which one do you go with? And I think at this point it's open. I think most of us, when you see higher number of lymph node involvement, we go with perioperative chemotherapy. If we see a larger primary site of tumor, and also maybe a little bit higher level at the GE junction, then we're more likely to use the neoadjuvant chemoradiation. But again, I think either one of those is a reasonable option. The next one, this wasn't presented this year at ASCO, but I think it's important to keep this in mind. This is data that was presented in 2021 and then published in New England Journal that looks at adjuvant nivolumab in patients who've had preoperative chemoradiation followed by surgery and have residual disease. These patients did benefit. If you look across the board, this is disease-free survival. And you see that there's significant benefit for these patients who received nivolumab. So this is squamous cell carcinoma at this point. Obviously, we're still going to, I'm sure we're going to have more updates to look at overall survival too. And this actually shows that there isn't, across the board, you see benefit for patients who receive the nivo in adjuvant setting. And so another way of looking at this is for patients who have had, again, distant metastasis-free survival. All right, so moving on to stage 4 disease. Interesting trial, I think that's important. This is another way of approaching HER2. So this is a study that was presented by Dr. Chawla down here. So this is basically a vaccine, if you will, Hervax. And this, you see the epitopes here that are used for this, and this basically is selecting patients who have HER2 positive disease, and that produces ADCC and also complement mediated response rate. The study is called Horizon, and when you look across here, you see that this patients are randomized 1-to-1, and they either received standard of care chemotherapy or standard of care chemotherapy plus this HER2 vaccine, and this is again an Indian trial. When you look at the outcome, you see significant benefits for these patients on this side. So just another way, obviously, we have, at least in the US, at this point we do, the treatments that we do is more infusional anti-HER2 agents, but this is something to just keep an eye out for the future. And again, you see if you look at the value here, you see significant overall survival in these patients, 14 versus 8. Okay, so the next one, I think this is an area that was probably the best part of the stage 4 data that was presented this year. something that should be on our radar now. So this is a drug, again, zolbetuximab with chemotherapy as first-line treatment for patients who have Claudin 18.2 positive and HER2 negative, for the sake of this study, in advanced gastroesophageal cancer, again, adenocarcinoma. So this is a phase 3 trial called Spotlight. And the idea is that patients who have Claudin 18.2 overexpression are, again, these tumors are targets. Now, going back, Claudin is a tight junction protein that's expressed in gastric and also in pancreatic and in lung, but 18.2 tends to be more specific to gastric. And in gastric tumors, a number of these gastric tumors actually have expression of this protein on the surface of the cells. And that's where this target comes from. So this is an antibody that basically targets this Claudin 18.2 and then leads to significant immune response for these patients. And that leads to response. So we'll be going over these, again, IgG1 monoclonal protein. Now, there were some older data, again, that looked at a different combination. So EOX also has been looked at in the older trial, but this is the first phase 3 trial that led to the approval. And so this is a 1-to-1 design for the Spotlight. You have about 280 patients on each arm. These are first line, so naive patients, Claudin 18.2, moderate to strong. So that's obviously a point for debate at this point. The way that they defined it on this study is greater than 75% of the tumors had to produce a 2+ stain. And HER2 negative, ECOG of, again, reasonable performance status, and then the stratification that you see there. Now, half of the patients received FOLFOX, modified FOLFOX6, which is a standard regimen that we use in first-line metastatic disease. The other half received the chemotherapy plus addition of zolbetuximab that you see was given every 3 weeks. And those patients who received the chemotherapy for up to, again, 4 cycles, and then after that dropped the oxaliplatin and continued with the 5-FU plus the antibody. And the other arm also the same thing, they dropped the oxaliplatin. When you look at the primary endpoint, progression-free survival is the primary endpoint. You also have key secondary endpoint is overall survival. And also response rate. So that's the breakdown for this study. Up here you see the PFS for these patients, so significant difference. This is comparable to TOGA trials that we saw with the HER2 targeting drugs. This is a PFS that you see here. This is also the OS on this side, that you see the significant improvement for these patients with a hazard ratio of 0.75 and significant p-value. So stay tuned for this. This should eventually lead to approval of this agent for patients who have Claudin 18.2 positive disease. And that is, at this point, this is a IHC test that obviously I'm sure FDA will approve a companion test for detecting this. At the bottom, you also see that it looks at OS subgroups in analysis, and across the board, the majority of the patients do benefit from this. Again, smaller studies when you look at the GE junction patients that seem to be sort of on the border, but for gastric cancer patients, it's significant improvement. As far as the side effects are concerned, there was that area, let me see if I can go back. Mainly the difference was the GI side effects that are listed up there. The rest of them were not that different when you look across both arms. So statistically significant difference across the study for progression-free survival and overall survival. And again, this is exciting. I think this is something that we look forward to and try to, hopefully once this is approved, we can get the patients who can go on additional of this drug. Now, I think also at the bottom, there is a study that was done with K-pox. That's the GLOW phase 3 trial that also showed positive outcome. Zolbetuximab is also being looked at with immunotherapy in patients with Claudin 18.2 positive disease. So that is an ongoing study called Illustro that hopefully we'll be hearing from in the near future. The last line, so this is not the first time that we're looking at Claudin 18.2. There's some older, smaller trials that looked at CAR-T targeting this, and it also looks pretty promising for refractory disease patients. Moving on, the next one is a study that looks at the value of regorafenib in advanced refractory disease in patients with gastroesophageal adenocarcinoma. And so this is called the Integrate 2A, and that's a study that basically randomizes the patients. This is 2-to-1. This is placebo versus regorafenib, 160 milligrams. Again, that's not a dose that we generally use. That tends to be pretty toxic, but of course that's something that you need for registrational trials purposes. And then the patients receive this day 1 to 21, every 28-day cycle until progression or acceptable toxicity versus placebo. Primary endpoint was overall survival. And if you look at the results, so the hazard ratio is 0.7, so significant improvement compared to placebo. So that this gives us, again, another option for these patients who have refractory disease and don't have access to clinical trials. And so hazard ratio of 0.68 within 12 months of survival. This is 19 versus 6%. I think that's important. This was done in Asia and also outside of Asia. There wasn't that much difference between the regions. So Rego is showing significant benefit for these patients, and that may become another option for our patients with gastroesophageal adenocarcinoma in the refractory setting. Of course, again, toxicity becomes another issue for these patients that we have to keep in mind. I think down here you see at the bottom there is another study ongoing, Integrate 2B. That's ongoing in Australia. The dose of Rego has been reduced to 90 milligrams, and that makes a lot more sense. This is a pretty tough drug to tolerate at 160. The next couple of studies look at addition of IO to first-line chemotherapy in patients. The first one is for patients with adenocarcinoma in metastatic setting. These are updates. So check MATE 649 followed by 648, which is the squamous cell carcinoma. So these are longer follow-ups for these patients who receive chemotherapy as first line versus Nivo plus chemotherapy. And this is the updated data. So overall survival up here, all randomized patients, and what was the primary endpoint, which was a CPS of greater than 5. You see a significant difference between the two arms in favor of nivolumab. Down here is progression-free survival. You also see a significant benefit when you look across the board. So it holds up when you have a longer follow-up for these patients. Obviously, the debate is, in this case, is where do you use the cutoff? What is the cutoff that you use for PD-L1 positive disease to treat these patients? I think what's important is, again, primary endpoint was CPS of 5. I think we have to be aware that patients who have a lower CPS score are less likely to respond. So we have to pay attention to that. I mean, when we talk to our patients, I think we have to rely more on chemotherapy than we rely on immunotherapy when the CPS score is low, as opposed to when it's higher. I know we have the access to that and it's approved for all comers, but we have to keep that in mind. The next one, this is the 648 update. These are patients with squamous cell carcinoma of the esophagus. Also a 29-month follow-up for these patients who's been done. Down here you actually see the schema for the trial. They did include an arm that had nivo plus ipi for these patients. So yeah, there are 3 arms. One is chemo, one is chemo plus nivo, and one is nivo plus ipi. And then the outcome, again, the primary endpoint of overall survival for these patients. Now, this was the primary endpoint. The PD-L1 was used, and you see significant improvement for the patients who had nivo added to chemotherapy in first line. Again, we have the all randomized patients versus patients who had positive PD-L1. And down here again, so we look at the 29-month follow-up for these patients. Also, if you look at, again, just a breakdown. Again, it's hard to really look at these, but you see across the board patients who had higher than one or higher had the significant response advantage when they received the nivolumab. Now, this one is actually looking at nivo, ipi versus chemo, and you also see the significant improvement across. So for esophageal squamous cell carcinoma, nivo and ipi is an option that could be used for these patients with advanced cancer. Down here is the PFS, up here is the OS, and you see that the PFS is not that different. And we do see that for double IOs in other diseases too. Whereas in the chemo plus nivo arm, PFS was also significantly different. But the OS tends to be improved. So again, that's the discussion. We probably have to tailor this to our patients, decide which patient would benefit from what and what makes more sense. Again, this is overall survival, just looking at the PD-L1 down here, and you see the improvement across the board for PD-L1 positive disease. As far as side effects, most of us have this experience. We've dealt with these drugs for quite a while, and really nothing that is surprising. This is the immunologic issues that we have to keep in mind and talk to our patients as they get treated. And down here, this is again a global study. Moving on to the next study, this is another agent that looks at, again, IO plus chemotherapy, something that also showed some improvement in patients with advanced adenocarcinoma, and study design up here. So you see this is the one-to-one randomization. They did use a PD-L1 of, this is 5% or above also for this study. And one-to-one randomization, so chemotherapy with placebo versus chemo, plus another IO that's explained up here. Significant improvement in PFS and also in OS. Again, subgroup analysis. Again, we need a little bit better breakdown of this. I think there's probably more data to come. This study also points to a CPS of 5 for these patients. Another option that I'm not sure at this point would be something that we will be using in the US. So here's a number of other studies that are ongoing looking at different immunotherapy agents that are in trials, looking at the studies for these patients. So a lot more to come. There is some studies that look at the bottom. So the top is colorectal. At the bottom, you see the gastric and esophageal squamous cell. So anti-TIGIT is something that we're all familiar with in lung, and now so it's being looked at in esophageal squamous cell carcinoma as well. So also stay tuned for this. A lot more to come to try to make this a more immunogenic disease. I'll stop here. Thank you. Any questions?
Any questions? Okay, thank you. Next up, I'd like to invite